Today, I will discuss a client who was initially referred to manage her cerebral palsy. The client is a 70-year-old female diagnosed with spastic diplegia cerebral palsy, a condition that in her case primarily affects the lower limbs but also impacts her hands, speech, and postural control. Her gross motor functional classification system score is a 4. In addition to cerebral palsy, she presents with a variety of other conditions, including hypertension, irritable bowel syndrome, urinary incontinence, osteoarthritis, osteoporosis, scoliosis, and lymphedema. Furthermore, she has a history of skin cancers, a chronic dislocated left shoulder, a chronically dislocated left patella. Over the course of her life, she has undergone numerous corrective surgeries for cerebral palsy, including bilateral tendon lengthening at age 5, bilateral patella lowering at age 11, and an arthrodesis at the left hip at age 12. She has also had a tonsillectomy at age 6, both gallbladders removed, and a hysterectomy in 1990. It is important to note that there is no documented history of physical activity prior to the referral. Cerebral palsy, while permanent, is not static. Its effect can evolve over time. Osteoarthritis is a degenerative joint disease, while osteoporosis is a skeletal disorder that increases fracture risk. Unlike many of her other conditions, osteoporosis is potentially reversible with the right interventions. The client faces several perceived barriers that may impact her engagement in physical activity or exercise, primarily stemming from her complex medical conditions. Firstly, her mobility limitations. Her spastic diplegia cerebral palsy, affecting the lower limbs, significantly reduces her ability to move comfortably, creating physical challenges in engaging with exercise. The additional impact on her hand, speech, and postural control further exacerbate the difficulty of performing many types of exercises, particularly those requiring balance and coordination. Secondly, chronic pain and discomfort. Conditions like osteoarthritis, osteoporosis, scoliosis, and a history of multiple surgeries contribute to chronic pain, stiffness, and joint instability. This may discourage her from participating in physical activity due to the fear of worsening pain or causing injury. Third, like previously stated, fear of injury. While with osteoporosis increasing her risk of fractures, the client may perceive exercise as a threat to her safety, especially if she is unfamiliar with appropriate low-impact exercise options that can strengthen bone without putting her at risk. Finally, a lack of confidence in previous inactivity. The absence of a documented history of physical activity indicates a potential lack of confidence and awareness of the benefits of exercise. Her long-term sedentary lifestyle may also contribute to a belief that physical activity is too challenging or not feasible for her. When considering the goals established by both the client and the clinician, the primary objective for the client is to manage her condition in order to maintain as much functional ability as possible. This aligns closely with the goals set by the clinician. Given the complexity of the client's medical condition, it is important to recognize that setting goals beyond functional maintenance may be unrealistic. The focus, therefore, remains on preserving her current level of function and preventing further deterioration, rather than striving for significant improvement, which may not be feasible under the circumstances. The client underwent 2 subjective measures and 1 objective measure to comprehensively evaluate her condition. The subjective assessments included the Depression Anxiety Stress Scale, or the DASS, and the Patient-Specific Functional Scale, or the PSFS. The DASS was employed to provide a comprehensive evaluation of the client's psychological health, encompassing potential emotional factors such as fear avoidance behaviors, which are often associated with chronic conditions. Research suggests that individuals with chronic illnesses, particularly those involving pain and disability, may develop heightened anxiety or fear surrounding movement, which can hinder their participation in physical activities. By identifying these psychological barriers, the DASS aids in addressing emotional factors that may negatively impact treatment adherence and outcomes. The PSFS was selected due to its ability to provide detailed insights into the client's current functional capabilities. This assessment goes beyond identifying pain, allowing the clinician to understand the specific functional movements that exacerbate discomfort. The PSFS enables the client to identify activities that are personally relevant, which in turn helps in tailoring interventions to target the functional limitations most important to the client. This directly aligned with the client's functional goals and improved the likelihood of achieving meaningful outcomes in their daily activities. Incorporating both subjective measures allows for a holistic understanding of the client's current physical and psychological health, enabling a more tailored and effective intervention strategy. The 2-meter walk test was chosen to objectively assess the client's mobility, endurance, and functional capacity while monitoring heart rate, blood pressure, and blood oxygen levels pre and post exercise. Given the client's spastic diplegia, cerebral palsy, chronic joint issues, and osteoporosis, this test offers a safe method for evaluating gait, balance, and mobility issues. Monitoring heart rate and BP is essential, especially due to her hypertension, as it helps assess cardiovascular response and avoid overexertion. Blood oxygen levels track respiratory efficiency, ensuring that light activity doesn't lead to hypoxemia. The test is simple, low impact, and can track progress over time, making it ideal for a client with multiple health conditions. Research supports walking speed as a key indicator of overall health, with slower speeds often linked to greater disability. Monitoring these physiological and functional measures helps create a tailored, safe, and effective intervention plan. The 2-meter walk test required careful planning and extensive precautions due to the client's lack of prior experience with such assessments and her limited understanding of the test's potential difficulty. Given her significant mobility limitations, multiple exercise physiologists were involved to ensure safety during the transfer from her wheelchair to her walker. The EPs closely monitored and assisted the client throughout the test, ensuring continuous support. The client was also explicitly instructed to discontinue the test immediately if she experienced any escalation in pain, prioritizing her safety and minimizing the risk of injury. 2 distinct exercise routines were prescribed for the client, tailored to her complex medical conditions. The first routine emphasized passive and active range of motion for the lower limbs, upper limb strength training, and assisted walking. Lower limb range of motion exercises such as passive leg extensions, internal and external rotation, and plantar and dorsiflexion were used and aimed to enhance joint flexibility and reduce spasticity. These were followed by resisted exercise, for example, leg extensions and leg curls, to improve muscle activation without overwhelming the joints. Upper limb strength training was focused on functional movements such as cross-body weight transfers to build practical strength. Assisted walking was the most challenging but beneficial exercise, requiring support to transfer from her wheelchair to her walker. Despite managing only 12 to 13 steps, this movement had the most significant therapeutic benefits, improving her perception of lower limb function. In her own words, this training helps to make her feet feel like they were hers again. The second routine involved hydrotherapy, combining assisted walking with exercises like squats, pull-ups, and unassisted walking, which reduces the impacts on the joints while maintaining strength and mobility. Additionally, single leg press and general mobility exercises were included to target overall body function. These routines were designed in accordance with the cerebral palsy guidelines, ensuring that the exercise intensity remained at a moderate level, appropriate for preserving strength, range of motion, and functional capacity in individuals with reduced exercise tolerance. Reflecting on the challenges faced during this case, one of the primary obstacles was the client's reduced energy capacity. Given her condition, it was essential to develop an exercise plan that balanced sufficient intensity without exhausting her for the remainder of the day or subsequent days. We were required to carefully manage her limited endurance to ensure that the exercises remained effective while allowing her to maintain daily function. Another significant challenge was the transfer process between her wheelchair and walker. After experimenting with various techniques, we discovered that for transferring to the walker, the client could nearly complete the movement independently, requiring only the stabilization of the walker for safety. However, transferring back to the wheelchair was more complex. The safest and most effective method involved supporting her under the knee and assisting her backward into the chair, as cupping under the arms was not feasible due to her chronic shoulder dislocation. Fortunately, the hip reinforced by the arthrodesis could handle the pressure. Prior to working with this client, I had limited practical experience with individuals with cerebral palsy and had never assisted in transfers. This experience significantly enhanced my understanding of the level of care required for such individuals and has deepened my knowledge of exercise prescription for clients with complex medical conditions. Thank you for listening.